talking about cardiac toxicology today, and I'm going to start with a review of electrophysiology and use that to talk about sodium channel blockers and openers and potassium channel blockers. I'm going to skip toxicologic tachycardia for time because we've recently discussed that in the toxidromes lecture, and because this was originally designed for a longer time slot. We'll spend some time on toxicologic bradycardia and toxins that can cause ischemia. So to just review the basic electrophysiology, we have a model of the myocyte, the cardiac myocyte here, and in the lower left corner we have the action potential. So this is the resting state of the cardiac myocyte, and for each ion there's going to be an equilibrium, and in the resting state the resting potential is basically because of the potassium channel being open. And so there's a resting potential of potassium that's based on the chemical gradient pushing potassium out of the cell, because there's more potassium inside the cell than outside the cell. And there's an electrical gradient pushing it in, and so that there's an equilibrium there, and basically there's no net movement of potassium, but it leaves a resting potential of -94. For phase 0, the sodium channel opens, and initially a couple of them open, and then that triggers more of them to open, and you have a large influx of sodium. And at the end of that, they change to inactive, meaning the channel's not closed, but it's inactivated. It's one of the 3 states of the channel. The sodium channel can be open, inactivated, or closed. This is the inactive state. And at the same time, the potassium channel is open, and potassium efflux from the cell starts to bring it back towards the resting potential. That's the notch. Then in phase 2, the calcium channel is open, and you have a balance of calcium coming into the cell and potassium going out of the cell, which on net basically leaves that plateau. Once the calcium comes into the cell, it binds to the ryanodine receptor on the sarcoplasmic reticulum and leads to a lot of calcium efflux from the sarcoplasmic reticulum. And then calcium binds to troponin C, causes a conformation change in tropomyosin, uncovers actin-myosin binding sites, and you get contraction, right? That's what couples the depolarization to contraction. At the end of phase 2, the calcium channel's closed, and then you basically just have calcium efflux is the main thing that's determining what's happening with the potential, and so the membrane potential goes back towards the resting potential. And then at the end, the sodium-potassium ATPase makes a sodium gradient. The sodium comes into the cell and pushes calcium back out of the cell, and it basically returns things to their normal state. And at this point, the sodium channel is closed. It moves from inactive to closed. So that's the cardiac action potential, and you want to kind of have an understanding that relates that to the surface EKG. So the P wave occurs during phase 4. The QRS, or the depolarization, is phase 0. That corresponds to sodium coming into the cell. The plateau is the kind of ST interval, and the repolarization, the T wave, is phase 3.
That's the ventricular myocyte.
Yes. So when we talk about prolonged QT interval, there's kind of 2 ways, or 3 ways actually, that you can prolong your QT. One of the ways is through effects on the sodium influx, because the QRS is part of the QT. But most of the time when we're talking about things that prolong QT, we're really talking about things that prolong the ST part of the segment, which is the prolongation of repolarization, and that's potassium channel effects. So here, this is a sodium channel effect that can prolong the QT by prolonging the QRS, actually by making the peak current higher. And so these are things that open sodium channels. Things that block sodium channels can also prolong the QRS, and that prolongs the QT. And then things that prolong repolarization are going to prolong the T wave and prolong the QT that way. So let's talk first about sodium channel drugs. And in the Vaughan-Williams scheme, there's the 1A, 1B, and 1C sodium channel blockers. And the main thing to remember is that 1As and 1Cs prolong the QRS significantly, whereas 1Bs don't do that as much. And it's because of the kinetics of the binding of those drugs to the sodium channel. So 1Bs are kind of fast on and off, and there's time for sodium to come through the channel in between when the drug is bound there. Whereas 1As and 1Cs are bound much more tightly to that channel. Probably the most important of the sodium channel blockers are tricyclic antidepressants, and we've talked about this before. The QRS prolongation is actually a better marker as a predictor of toxicity than levels of tricyclics in the blood, because you're basically directly measuring toxicity. So QRS over 100 is a 1 in 3 risk of seizure, and QRS over 160 is a 1 in 2 risk of dysrhythmia, based on the study by Bonner and Lovejoy. Another marker of sodium channel blockade is what's called the terminal 40 millisecond right axis. And basically what you're having is at the end of your QRS, if you look at the leads that look at the heart from the right, which is AVR, you're going to see an upward deflection of the QRS. So that R wave at the end of the QRS complex in AVR is a marker of sodium channel blockade as well. So here's an EKG that kind of combines all the classic features of sodium channel blockade, is that you get the widening of the QRS and the terminal 40 millisecond right axis, that upward deflection at the end of the QRS in AVR. This isn't classic for a tricyclic in that there's no tachycardia in this EKG, which is the other thing that you would expect to see with a tricyclic poisoning. So the treatment for sodium channel blockade from a tricyclic is sodium bicarbonate, and there's two different effects you get from sodium bicarbonate. One is the sodium effect, giving a sodium bolus, and it overcomes that sodium channel blockade. When you start an infusion, you're not getting the sodium bolus anymore. In that case, you're relying on the pH effect, the fact that the tricyclics have a lower affinity for the sodium channel at higher pH. Is the reason that we do an infusion. When you give a bolus, you get both of those effects. When you start an infusion, you're not getting the sodium effect anymore, you're just trying to affect the affinity of the drug for the channel. Another strategy you can use if the pH is getting high, you could try using hypertonic saline boluses. Obviously, there's a potential risk involved with that if you're going to be too aggressive with it, but it's another thing that might potentially work, although it's not studied. Lidocaine is a little bit counterintuitive, that you have sodium channel blocker poisoning and you treat it with another sodium channel blocker, but the idea is that you give the less toxic sodium channel blocker, the 1B, and hope that some of the channels are protected from the more toxic ones, is the kind of basic idea behind that one. Magnesium can sometimes be used, and then one thing you don't want to give is physostigmine. We talked about that during the toxidromes lecture. There are some other sodium channel blockers out there that I'm going to mention. A lot of them are more neurotoxic than they are cardiotoxic. Tetrodotoxin is one that is in a lot of media, talking about fugu, the pufferfish, sushi, and they are sodium channel blockers, but they're mostly neuronal sodium channel blockers more than in the cardiac myocyte. There's sodium channel activators, and these are some of the plants that may be involved. Monkshood is the top left, and then going clockwise is rhododendron, delphinium, larkspur, and veratrum. And these sodium channel activators actually do affect your heart and can lead to dysrhythmias. The treatment would be lidocaine or amiodarone for most of these, and you could try pacing or bypass. Here are some other sodium channel activators that tend to be more having effects on the neuronal sodium channels. The poison dart frogs, paralytic shellfish poisoning, and ciguatera. And then these are some sodium channel modifiers. The cone snails and the funnel web spider block inactivation of the sodium channel. So let's look at some potassium channel drugs. Remember that here we're prolonging the T wave and prolonging the QT that way. When you prolong the T wave, what can happen is that can lead to a delayed after depolarization. And what happens is basically, if that occurs when the cell is no longer refractory, it's going to trigger a new action potential. And so here you can see some delayed after depolarizations, that kind of shoulder on the side, on the end of the T wave. You can see it well on the rhythm strip in the end. You can also have early after depolarizations, and if these occur while while the cell is no longer refractory, it can actually trigger torsade, which is the biggest risk of having prolonged QT. Kind of classic torsade picture. So when we think about potassium channel blockers causing dysrhythmias, you have a toxin, in this case, or it can be ischemia, causing an altered substrate. You have prolonged repolarization. And then if you get an early after depolarization or a delayed after depolarization that occurs on that altered substrate, it can trigger dysrhythmias. So some common offenders, some of our psych medications, haloperidol, droperidol, chlorpromazine, high-dose methadone, cisapride, erythromycin and clarithromycin, terfenadine. Obviously, the antidysrhythmics can be pro-dysrhythmic as well. Arsenic and amiodarone. Amiodarone is probably the only one of these that doesn't predispose you to a dysrhythmia, and I'll talk about why that is in a sec. There's actually way more of these drugs, and it's way more than you're really going to ever remember. So a useful resource is qtdrugs.org. So if you have a patient with a prolonged QT, obviously you're going to check their potassium, their calcium, and their mag, and then you look at their med list, and you're not going to remember every single drug on their med list, whether or not it's a QT drug. So you can go to the website, and in addition to just listing the drugs that are on the list, it also gives you a sense of how common it is to see QT prolongation with those drugs, so you can get a sense of the actual risk. Yeah?
And I know there's many drugs, but Zofran also?
Well, it's now on the list of causing torsade. I'm not so sure about whether it's a potassium channel blocker or not. I know that all new drugs at this point are tested for their effects in vitro on the potassium rectifying current. It's one of the screening that's required for new drugs now because it's such a common thing as an adverse effect of a lot of drugs. I'm not sure whether ondansetron was before or after that was required or whether that's been studied. Any other questions? I'll go on. So treatment for torsade from potassium channel blockade. Obviously, if somebody's in torsade, that is a form of ETAC, and electricity is usually going to be your initial treatment. You can do cardioversion. You can think about overdrive pacing, depending on how stable they are. Calcium channel blockade in the form of giving magnesium is another treatment. You can use lidocaine or amiodarone. And again, it's a little bit counterintuitive that a potassium channel blocker like amiodarone would help for this, but it has a lot of other effects in addition to being a potassium channel blocker. And then beta blockers can help prevent another episode by preventing that stimulus on top of the substrate of prolonged QT. So here, this is a beta receptor, and if epinephrine is triggering the beta receptor, if you block that effect, it's going to block the effect of the beta agonists on the myocyte and potentially prevent triggering that early after depolarization or delayed after depolarization. So just a mention about amiodarone. I've been talking about how it's a potassium channel blocker, but it doesn't tend to cause torsade. And the reason is that it has all these other effects too, right? It's a sodium channel blocker, it's a calcium channel blocker, it's a beta blocker, and it decreases cell-to-cell conduction. So of all the drugs that prolong your QT, it's the only one that doesn't really cause torsade, mostly because it kind of treats itself through its other effects. So this is an example. It's basically blocking everything in the cardiac action potential. So this is basically what I just said. All right, so I'm going to skip toxicologic tachycardia, as we said, for time, because we talked about this with the Crohn's lecture. And I'll briefly talk about methylxanthines. I don't know if you all remember Michael Falk when he was here. But methylxanthines include caffeine, theophylline, and theobromine. And these are all drugs that have a lot of similarity to adenosine. And one of their mechanisms of action is that they're adenosine antagonists. And what that does is cause release of endogenous catecholamines. And that release of endogenous catecholamines is actually through adenosine antagonism, and I'll show you why that is in a second. They're also phosphodiesterase inhibitors, and that mostly occurs in overdose. It doesn't typically occur in a therapeutic dose. So if you look at a neuron that contains catecholamines, in those synaptic vesicles that contain your neurotransmitter, there's also adenosine in there. And the adenosine is a negative feedback mechanism. So after you release neurotransmitter, you're also releasing adenosine. Adenosine binds to presynaptic receptor and prevents further release. If you have a methylxanthine there, it blocks that feedback at the adenosine receptor on the presynaptic neuron, and so you get more release of catecholamines. And if you have asthma, then that potentially is good, right? Because you're releasing more epinephrine, and you're going to wind up having bronchodilation. And if you want to have a little bit of extra adrenaline when you are tired, then you can take some caffeine and it'll do kind of the same thing. There's also effects in the brain, and actually I should just mention, when we talk about theophylline, theobromine, and caffeine as methylxanthines, the xanthine is that double ring structure, and you can see the methyls on it. Theophylline and theobromine each have 2 methyls in different locations. Caffeine has the 3rd methyl, and so that extra methyl makes it more hydrophobic. It makes it go into the brain better, and it's why it's more effective as an agent to keep you awake, because it gets into the brain better than the other methylxanthines. It's also why it's worse if you're in overdose, because it causes seizures and gets into the brain that way. So in terms of the signs and symptoms of these things, the kind of classic things that you're going to see in an acute overdose with methylxanthines is going to be nausea and vomiting. In chronic overdose, that might not be as reliably seen, but it's one of those drugs that if you're not vomiting, you didn't take enough acutely to hurt yourself. It really reliably causes vomiting. It causes, obviously, all of your adrenergic effects and your cardiovascular system, and in the neurological system, you can see tremors, you can see seizure is going to be the most important one in overdose. And then you get a lot of metabolic derangements: hypokalemia, hyperglycemia, hypomagnesemia. You get metabolic acidosis and respiratory alkalosis, and rhabdo and renal insufficiency. So I'm going to skip some of this for time, but when you get a theophylline overdose or a caffeine overdose, this is something that you're going to need to check serial levels to see where you are, and particularly for theophylline, most preparations are going to be sustained release, so it's going to be a long-term problem. Skip this. In terms of treating these patients, we typically give them something to control the vomiting and then correct the metabolic derangements. In the brain, one of the big problems is that when you have a seizure, adenosine is one of the things that causes pauses in the seizure and gives your brain a chance to kind of refresh in between. When you have a seizure associated with an adenosine antagonist, you basically, if you look at an EEG, are going to have just continuous seizure activity in the brain. So it's actually worse than other forms of status epilepticus for the brain. And so the seizures can be particularly difficult to manage because of that. Skip this and just get to the treatment part. GI decontamination is going to be important, and sometimes patients, as I said, are usually already vomiting. Once you control the vomiting, multi-dose activated charcoal, this is actually one of the drugs for which it's best studied, and it significantly increases the clearance of the drug. That gut dialysis model is something that's actually been proven to occur for theophylline. So even if you have no theophylline left in your GI tract, giving multi-dose charcoal will enhance the elimination by pulling it out of the blood and into the GI tract. And it's actually almost as good as dialysis, although not quite. So yeah, here comparing not doing anything on the left, doing dialysis in the middle, and charcoal hemoperfusion on the right is another way to enhance the clearance. I'm going to skip this. Charcoal hemoperfusion, does anybody here know what it is? Have you ever seen it done? No. So charcoal hemoperfusion, Joel has seen it done. I think the only one in this room. Charcoal hemoperfusion is a similar concept to dialysis in that it's an extracorporeal circuit that you run the blood through. But rather than running it against a dialysis membrane, you run it through a cartridge that contains charcoal. So the blood is running through the charcoal and then is returned to the body. So the charcoal removes the toxins from the blood, and then the blood is returned. It doesn't correct electrolyte abnormalities and things like that, although sometimes it can be done in series, where you run it through the charcoal cartridge and then through the dialysis cartridge. The problem with it is that almost nobody retains the ability to do this. The cartridges are expensive, they expire, you rarely need them. And so there was a study where they did a survey of various dialysis centers, and almost nobody has cartridges of this kind left. And it's probably not that important because the newer high-flux hemodialysis machines are actually pretty close in their clearance of toxins to hemoperfusion. So 3 is of theophylline, 3 mechanisms of action. They cause catecholamine release, there's adenosine antagonism, and they're phosphodiesterase inhibitors. 3 signs of severe toxicity: seizures, dysrhythmias, hypotension, and then 3 treatments: multi-dose activated charcoal, hemodialysis, and charcoal hemoperfusion. Okay, now I'm going to talk about toxicologic bradycardia. And there's 5 drugs in the differential, or 5 categories of drugs in the differential diagnosis of bradycardia from a toxin: beta blockers, calcium channel blockers, cardioactive steroids, things like DIG, imidazolines like clonidine, and cholinergics. I should mention that the calcium channel blockers is not all calcium channel blockers. So basically, diltiazem and verapamil. All the other calcium channel blockers, the dihydropyridines, you may actually see reflex tachycardia because they primarily affect the calcium channels in your vasculature and cause vasodilation, and not so much the calcium channels in the heart. So let's look at beta blockers first. The kind of classic manifestations of beta blocker toxicity are bradycardia, hypotension, hypoglycemia, and hyperkalemia with altered mental status. And the altered mental status can be one of the things that can help you distinguish it from calcium channel blocker poisoning. And this is particularly true of more lipophilic ones like propranolol. Even in a therapeutic dose in an elderly patient can sometimes make a patient kind of confused. Let's look at hypoglycemia from beta blockers. And this is a cascade that looks at the effects of adrenaline, ultimately causing release of glucose from glycogen. And if you block that, ultimately downstream, you're going to wind up blocking the breakdown of glycogen and release of glucose. So that makes you prone to hypoglycemia. Hyperkalemia is kind of an intuitive concept when you think about the fact that we give beta blockers to, we give beta agonists to lower potassium for hyperkalemia. If you have beta blockers, they can lead to higher potassiums. And this is just a study looking at people who are dialysis patients, if they're on placebo versus on beta blockers, and just their resting potassium and their rate of potassium rise over time. So when you have calcium channel blocker poisoning, you get a little bit different. You get the hypotension and the bradycardia, not just less with dihydropyridines, but it doesn't really occur with dihydropyridines. Hyperglycemia, not really any effect on potassium, and a relatively preserved mental status. And calcium channel blockade is actually neuroprotective. It's been studied in a couple of disease states like traumatic brain injury and stroke. And the idea is calcium influx into the cell is one of the triggers for apoptosis. So in areas that are potentially injured, that kind of surrounding area is often apoptotic. And so, blocking that calcium channel potentially can prevent injury to the brain. And in most of those studies, the problem with it is that you need to be pre-treated before the injury. Whereas if you have a calcium channel blocker poisoning, you kind of are pre-treated. You're getting the protection at the same time that you're getting the poisoning. So it actually preserves the mental status. It's protective of the brain. This is a beta islet cell in the pancreas, and calcium channel blockers also have an effect here. One of the final trigger for insulin release from the beta islet cell is calcium influx into the cell that leads to release of the granule that contains the insulin. And that happens to be an L-type calcium channel. Now, those channels are not blocked in a therapeutic dose of a calcium channel blocker, but in overdose, it starts to affect these. So you block the final trigger for insulin release from the beta islet cell, and so you get hyperglycemia as a manifestation of calcium channel blocker poisoning. So let's look at cardioactive steroids. They can cause pretty much any kind of dysrhythmia. You can, the only thing you cannot get is a rapidly conducted atrial tachycardia, right? So you can get bradycardias, and we'll talk about why that occurs. You can get VTAC and VFib. You can get AFib or SVT with a high degree of block. The only thing you can't get is rapid AFib or SVT with rapid conduction. And we'll talk about why that is and some of the EKG manifestations of this. Headache, nausea, and vomiting are really classic, especially in chronic DIG overdoses. We see that a lot with some of our elderly patients who are usually actually the only ones who are still on DIG at this point. But that's a kind of classic finding. And then chronic overdose, you'll often see it in the setting of worsening renal function. Now, patients who are dialysis patients actually can be on DIG because there's hepatic clearance also, but it's a different dose. And one of the settings that we'll often see DIG toxicity is a patient who's on a chronic therapeutic level of DIG and then has a change in their renal function and winds up accumulating a toxic amount. And then the visual change is kind of a big clue, and it's one that you'll often see on exams. And the visual change that's most often described as this kind of halo glowing around lights and Starry Night. Van Gogh's painting is usually the example that's given of that, what that looks like. So in terms of the rhythms, again, bradycardia from vagal tone, tachydysrhythmias in the atrium and the ventricle are because of irritability of the myocardium, and we'll talk about what that means. And then rapid atrial rhythms with slow ventricular response. So this is our model of the cell. When you have a beta agonist binds to the beta receptor, sorry, let's go back. When you have a beta agonist bind to the beta receptor, it triggers the second messenger system. Adenyl cyclase converts ATP to cyclic AMP. Cyclic AMP activates protein kinase, which activates the calcium channel, increases calcium influx into the cell. And then ultimately, at the end of the action potential, remember that when you have a lot of calcium in the cell, you're going to need that sodium gradient to drive the sodium-calcium exchanger. Remember, cardioactive steroids like digoxin block sodium-potassium ATPase. You have less of a gradient there to get the calcium out of the cell at the end of each action potential. And what that leads to is more calcium in the cell at all times, and that extra calcium in the cell is great if you have congestive heart failure because it gives you more inotropy, right? More calcium in the cell is going to uncover more actin-myosin binding sites, and it's going to increase your squeeze. But what that extra calcium in the cell also does is put more positive charges in the cell and makes the membrane potential more positive. Right, everybody gets that? So that more positive membrane potential is closer to threshold and makes the cell more likely to depolarize. And that's what we mean by irritability. It's just more likely to trigger and set off a depolarization. So that has nothing to do with why you get bradycardia, right? Because the bradycardia isn't in the myocyte. What happens is that you get a very similar effect in the vagus nerve, and the vagus nerve is more likely to depolarize and inhibit the AV node and basically decrease the amount of depolarization you're going to get in the myocardium because of that. Kind of classic things you can see on EKG, DIG effect. So you can see PR prolongation, and this kind of scooped ST depression is a really classic DIG effect. If you learned your EKG reading from Dubin, you may remember this being called Salvador Dali's mustache. It kind of looks like half of his mustache, so if that helps you remember it, that's great. Another thing that can help you, so that can be a good way to identify if it's DIG toxicity on an EKG. It doesn't mean that the patient's toxic. It means that the patient has DIG on board. Patients on a therapeutic DIG can have that effect on their EKG. But if you have a patient who clinically looks like they're potentially DIG toxic and you see that effect, that can kind of help you identify that as the etiology, like a bradycardic rhythm, for instance. In general, cardioactive steroids have a better blood pressure with their bradycardia than you'll see with a beta blocker or a calcium channel blocker, because they increase inotropy, kind of compensates for the bradycardia, and it's going to give you a better blood pressure than you'd expect for the heart rate. So people get confused sometimes by the role of potassium in patients with ditch poisoning. And the most important thing here is to separate acute ditch poisoning. Somebody takes a handful of digoxin pills or eats a cardioactive steroid-containing plant, and chronic ditch poisoning, patients accumulate a supertherapeutic level over time. So in acute ditch poisoning, you're blocking lots of sodium, potassium, ATPases all over the body, and then that leads to a lot of extracellular potassium, and so a high potassium after an acute overdose is a marker of a poor prognosis because it means you took a lot. Right? And this comes from a study by Chantal Bismuth. This was before there was an antidote to ditch poisoning in 1973, and she basically looked at if you took an overdose of digitoxin, because this study was done in France and that's what they had, and not digoxin, and what the potassium was when you arrived to the hospital, and then did you live or die. So if your potassium was over 5.5, everybody died. And if your potassium was under 5, everybody lived. If it was between 5 and 5.5, you had a 50-50 shot. So let's look at chronic poisoning. So in chronic overdose, if you have a low extracellular potassium is fewer positive charges outside the cell. That's the same from an electrochemical perspective as more positive charges inside the cell. Right? And so that is also going to make the myocardium resting potential higher, and it's kind of exacerbating what DIG does to the resting potential. It makes it more likely to depolarize, and so low potassium increases the risk of dysrhythmia and signs of toxicity at any given DIG level. Everybody got that? All right, cool. So this is a table. I love to make these tables kind of looking at features that can distinguish between different things that cause the same clinical presentation. And in this case, the clinical presentation we're talking about is bradycardia. So heart rate, obviously, they all cause low heart rate. That's why we're talking about differential diagnosis of toxicologic bradycardia. But just keep in mind that dihydropyridines don't do that. Blood pressure, for most of the beta blockers, calcium channel blockers, clonidine, are going to cause low blood pressure. Remember, if you see a pretty good blood pressure with that bradycardia, it's maybe more likely to be a cardioactive steroid. The history may help you in terms of what diseases somebody has, what kind of drugs they might be on. Unfortunately, a lot of these are similar. People with AFib might be on any one of the first three. People with clonidine exposure may have some kind of opioid-like effects. So that may be a clue. People with opioid history, there's actually a street market for clonidine because it attenuates the symptoms of opioid withdrawal. And then the cholinesterase inhibitors, if somebody has Alzheimer's dementia, they may be on Aricept, or if they have myasthenia, those are the diseases that somebody might be on a cholinesterase inhibitor, or if they have a history of pesticide use. The mental status may help you. The beta blocker patient is typically going to be confused and altered, whereas the calcium channel blocker patient is going to have preserved mental status. Cardioactive steroids may be altered, but not necessarily. Clonidine patients